first step was we did a literature research and analysis. And from this literature research, we searched the most important systematic reviews and most important papers where we thought they were most interesting for us. And from this analysis, we identified the most important influencing factors and accompanying challenges. And in a next step, we wanted to discuss these influencing factors and challenges with international experts and also persons involved. On the left-hand side, you see the names of the interviewed experts. It was really a pleasure to talk to them and to get insights into their history and developments of interprofessional education in the respective countries. So this was really, really interesting and very, very in part funny to hear the stories from the different countries. So at this side, thank you very much to these experts. And we also conducted interviews with persons involved, like here you see it on the last lines, Lukas Büser was a medical student, or Christina Galfetti was a patient, both from Switzerland. And they conducted those interviews orally or in written. And from this second step, we derived measures and recommendations for action. And let's have a, it's the animation again. I'm sorry. Let's have a look at the first results. We derived 31 measures and merged them into 6 overall recommendations for action. And you can see it through the different wordings. First of all, we derived that, and maybe this might be familiar to you, you need to have the stakeholders in education, research, practice and policy on board. And in a second recommendation for action, you need to have learning objectives and competencies. And of course, third, these objectives and competencies should be included in the curricula. And we also saw that the role of the facilitators is very, very important, deciding if interprofessional setting is successful or not. And we derived also that interprofessional education must or should be practical and efficient, and furthers the potential of research needs to be exploited. And in the green boxes, you see some examples. I can present 31 measures to you. Might be interesting, but I did some excerpts on that. Is e.g. for the first recommendation for action, we suggest to establish a national network of research, practice, and educational institutions on interprofessionalism and networking with local interinstitutional networks. And example for the second point is interinstitutional coordination and support within the institution to achieve a mandatory implementation of interprofessional learning goals and competencies. And an example for the third recommendation for action would be anchoring interprofessional education formats in the curriculum as a longitudinal thread. And for the facilitators, there might be a suggestion to implement a facilitator toolbox and to create a community of practice for facilitators. Example for the fifth point might be a nationwide implementation of practical interprofessional education formats, such as interprofessional training wards and clinical and or outpatient care. And for the last point, maybe example, long-term establishment of multi-institutional interprofessional research groups. In the last step, we wanted to discuss those measures and recommendations for action with national experts and to derive a roadmap for Switzerland. Now we have these general recommendations, and we wanted to drive this discussion on this general recommendations forward and to derive actions for and recommendations, especially for Switzerland. And that's why we conducted a national workshop with national experts from different countries in different cantons in Switzerland. It was around about 24 experts, also including a student and a patient. And let's move to the results on this. Also, I can give you only examples of this roadmap. And you see on the left-hand side, on the first column, the respective recommendation for action I already introduced to you. And then you see what we wanted to achieve in this workshop. We wanted to find out which measures are the most important and which next steps could be conducted to achieve these goals, and what should be the most important actors to take part on that, and by then should it be achieved or conducted. And as an example, let's take this recommendation for action 1 concerning the stakeholders. An important measure was, like mentioned previously, setting up a national network of research, practice, and educational institutions. And the next steps could be setting up a committee with international participants to initiate the creation of a national network. And here the patrons could be involved, the Federal Office of Public Health, Swiss Academy of Medical Sciences, or the CAIPE Foundation. And who should be member of this network? Those responsible for medical, nursing, therapeutic, and medical technology training courses, education as well as continuing education, also patient representatives and representatives of various healthcare settings, meaning inpatient, outpatient, or maybe also health insurances. And it would be nice to conduct this or achieve this until the end of 2021. And we did this with all those recommendations for actions and the concerning measures. And here you on this slide, you see recommendation for actions 4 to 6. And maybe as another example, let's have a look at this recommendation for action concerning the role of the facilitators. A measure would be designing and implementing a facilitator toolbox to support the quality of education and establish a community of practice for these facilitators. And the next steps might be preparing a publication, a paper, to clarify what's behind this term facilitator. You know, we have different terms: supervisor, coaches, managers, and educators, and also have facilitators. And what's behind this facilitator term, and designing a facilitator toolbox for Swiss facilitators, and of course establish a community of practice for these facilitators. And again, we have these actors, workshop participants, CAIPE Foundation, and so on. And we want to achieve this early 2021 and mid 2021 and the end of 2021. Yeah, these are just insights into this roadmap and examples on what we achieved and derived. And to conclude, country-specific recommendations for interprofessional education can be derived from interviews with international experts, and maybe also interesting for further or other countries. And now in future, the realization of concrete steps will be examined and initiated in collaboration with the actors as known in the roadmap. And just a note on this working paper: if you want to download it, it's available at this URL, or you can Google CAIPE Working Paper 9, and then you should find it. It's also available in English language and maybe interesting for you. Well, so far, thank you very much for your attention. Sorry for the animations and looking forward to the discussion. Thank you very much. Also to the depicted experts, international and national, thanks for that.
Thank you very much, Gert. Very informative, interesting, stimulating presentation for the first one this morning. I think you, for me, have highlighted, and it's something that's been considered globally before, but there's a need to look at what is the global language terminology of interprofessional education, collaborative practice, facilitation, etc. So some good lessons there. I'm not sure if our CAIPE board member, Andreas Icarus, who is editor-in-chief of the Journal of Interprofessional Care, is looking into terminology, but I know there was a group that was sort of looking at trying to come up with some globally agreed terminology for IPE, etc. If you'd like to stop sharing your screen now, we'll see if anybody's got any questions.
Maybe I can add this. I think there was.
If you want to share your screen, and we look forward to your presentation on the development of an interprofessional education model using a design-based research method. Fantastic to see you're all getting the technology right. This will provide some good recordings on the Interprofessional.Global website. So over to you, Gérard.
Thanks, Richard. I received some good training, so I'm glad the training paid off. Good morning, everybody. I'm Gérard Filies. I'm an occupational therapist by profession, and I'm currently a senior lecturer at the University of the Western Cape, and I'm based in the Interprofessional Education Unit in the Faculty of Community and Health Sciences. This morning, I'm presenting a paper that is from my PhD study. And I'd like to just take you through the process that I went to in designing an interprofessional education model using a design-based research method. So Frans and Rode, two of my colleagues at the University of the Western Cape, wrote a paper around a scaffolding model for IPE, and they state that IPE should be seen as a vehicle for bringing about change for improved healthcare, since it creates an opportunity to change the current method used to educate future healthcare professionals, embark on research, and engage communities. These changes will require universities to produce T-shaped graduates that are both extremely knowledgeable about their own profession, as well as skilled and willing to learn new skills and explore other fields as part of their work or study for various reasons. Van Heerden clearly states that students need to become agents of change in order to address the complex and ever-changing needs of society. In order to do this, students will be required to develop certain competencies which are aligned and facilitated with the concept of T-shaped graduates. These competencies include graduate attributes as are outlined by the university and to be attained by students before graduation, together with IPE core competencies as outlined by the Canadian Interprofessional Health Collaborative. Frans and Rode categorize the Faculty of Community and Health Sciences as a faculty within a resource-constrained university and highlight three specific concerns in terms of the implementation of IPE and IPP. The concerns include the lack of an explicit framework, challenges operationalizing IPE and IPP, and the lack of a critical mass in terms of human resources to drive both IPE and IPP. Although there is a lack of an explicit framework for IPE, France and Rode introduced the concept of a scaffolding approach to learning, which provides guidance in terms of how IPE is being implemented at the university. The Leicester model of interprofessional education, as outlined by Lennox and Anderson, was used as a guideline for the study. This model is ideal as it shows the context setting within the overall health and social care curriculum within the Faculty of Community and Health Sciences. The outer circle presents profession-specific learning, and the middle circle refers to the core competencies shared with other professions, which can be learned as a shared learning experience or in uniprofessional situations, for example, with communication skills. The inner circle represents interprofessional learning in which students learn about, with, and from one another to improve collaboration and the quality of care. The three circles therefore represents and form the setting of the model that I designed. With regards to the methodology that I used, the study employed a mixed method, sequential exploratory approach. The design-based research method was best suited for the study, as the rationale behind the use of design-based research is that it focuses on using design in the service of developing broad models of how individuals think, know, act, and learn. Design-based research is a method that combines design and scientific methodology, allowing researchers to produce useful tools and effective theory for solving specific problems in education. The design and design-based research process entails 6 interrelatable phases, and those are focus, understand, define, conceive, build, and test. In this study, the last 2 phases were not carried out since the focus was only on designing the model and not to test it. So as you'll see next to each phase, I had a specific methodology that I focused or that I used. So in the focus phase, I conducted a systematic review, and this was to assess and describe the intervention strategies used to develop and evaluate interprofessional core competencies in students. In the understand phase, I conducted or I used the tool, the Readiness for Interprofessional Learning survey, the ripples. And this I carried out amongst our first and senior students. This phase was later repeated after the defined phase to map out the IPE curriculum and to identify the IPE competencies and general attributes required for graduate employability. In the defined phase, I used the Delphi method to reach consensus amongst an expert panel in terms of the most appropriate activities and assessment methods to use in an interprofessional curriculum that would assist in instilling the interprofessional core competencies in allied health students. In the conceive phase, this is where I obtained or I used information from the previous phases to design the IPE model, which I will elaborate on in the following slides. I just want to explain further in each phase findings from each of the phases. So at the time of the study, when I conducted the systematic review, which is the focus phase, It revealed that there were no South African studies that provided evidence of IPE core competency development in curriculum design. The systematic review highlighted global interventions that specifically focused on instilling interprofessional core competencies. These interventions covered three core areas: the IPE context, core competencies addressing using various strategies and assessment strategies, and the outcome of the review also highlighted the need for a clear curriculum framework which highlights the IPE outcomes, activities, and assessments in alignment with IPE core competencies at each year level. In the next phase, the understand phase, I use the ripples to identify various key factors which affected the students' readiness to learn. These factors included a willingness to collaborate, the year level of the students, and the influence of gender and exposure to IPE activities. Findings from this phase followed that the students valued collaborative learning with other healthcare professionals, as well as sharing experiences with them. Another significant subgroup finding was that the senior students scored higher than the younger students on the Ripple survey subscale, meaning that they agreed more often with items in the survey, stressing the values of teamwork and collaboration, professional identity, and roles and responsibilities. Gender seemed to influence the scores in this phase as well, where I found that females valued professional identity, teamwork, and collaboration. The final significant subgroup finding was the discipline which had the least exposure to the current IPE activities in the faculty had significantly lower scores on teamwork and collaboration subscales. The expert panel in the Delphi study, which is the define phase, highlighted a range of activities and assessment methods to develop IPE core competencies, and consensus was reached during round 2 of the exercise. The preferred activities that are common across all the core competencies were case studies, joint clinical placements, simulations, role plays, and workshops or discussions. The preferred assessments for each of the above activities that related to each of the core competencies were portfolios, reflection, and the use of rubrics. Later on, a repeat of the understand phase, which involved curriculum mapping, gave an overlap between the IPE core competencies and the university graduate attribute document. And this brought about the culmination of generic competencies, which was then used to design the IPE model. In the conceive phase, the findings from the previous 4 phases were used to further expand on the scaffolding model by France and Roda, by including an IPE module in curriculum development. The significance of the expansion of the module was to provide the teaching and assessment strategies that can be used to develop the competencies. Findings from the 4 phases that were used to further expand on the scaffolding model by France and Roda were then conceptualized and presented as follows. In the first year, suggested content or curriculum activities could be through IPE theory courses, concept discussions in the form of a World Cafe, together with faculty development activities. The competencies aligned to these curricular activities were interprofessional communication and team functioning. Activities aligned to these modules and competencies were case study discussions and discussions or workshops. To assess these activities, the suggested assessment Activities were role plays, discussions, rubrics, and reflection. At the second year level, suggested curricular activities are IPE theory courses and then case studies that could be used in World Cafe type activities. Competencies aligned to these curricular activities were patient, client, family, community-centered care, team functioning, and role clarification. The suggested activities to use, according to the expert panel, were case studies, simulations, workshops, and discussions or discussions. To assess these competencies, the use of portfolios, rubrics, and reflection. At the third year level, it was found that most students do either field work or clinical practice. And in clinical practice, the competencies that could be assessed or embedded were interprofessional communication, patient, client, family, or community-centered care, role clarification, team functioning, collaborative leadership, and interprofessional conflict resolution. To assess these competencies or activities that could be used were case study discussions, joint clinical placements, and simulations. Again, to assess these activities or competencies in these activities would be portfolios, rubrics, and reflection. At a fourth year level, curricular activities could be an interprofessional research module or an interprofessional ethics module. Competencies that could be embedded in these activities were interprofessional communication, role clarification, team functioning, collaborative leadership, interprofessional conflict resolution, and then values or ethics for interprofessional care. The activities were case studies, simulations, workshops, or discussions. Suggested assessment strategies could be portfolios, rubrics, and reflection. Although the postgraduate curriculum is not part of this module yet, in future, students could engage in interprofessional research projects with the outcome of producing a collaborative proposal, with each student undertaking an objective of the study for the dissertation. In conclusion, I'd like to end with a quotation by Ralph Ellison, that says, "Education is all a matter of building bridges." And if we consider the expanding IPE scaffolding model that I present,
Gérard, I think you've frozen for some reason.
And then we hope it's working. Okay. Seems good. Okay, thank you very much again. And really looking forward to have this presentation. And I'm more than happy to conduct this presentation in common with my colleague Anthony Breitbach from St. Louis University. And we conducted an international cross-sectional survey, and it was about interprofessional collaboration in international sports science and sports medicine. And I think I can quickly hand over to Tony.
Yeah, hello. Thank you very much, Gert. I really appreciate this collaboration. Thank you for reaching out to me. And this is really has really set the stage for a lot of good things that followed. So when we looked at the background of interprofessional collaboration in sports science and sports medicine, there is some literature in the area, but we found that patient outcomes can benefit from collaboration. And however, to present a common picture of the professions working in the area is very difficult. I think there's a wide diversity globally how these professionals work and interact. And up to this time, there really has been no international perspective on how interprofessional education, interprofessional collaboration happens with all the various professions that work in sports science and sports medicine. An example of how complicated the fields are is really the definitions of the different professions from country to country. So if you think about in the United States, athletic trainers and physical therapists, work in this area. Athletic therapists in Ireland and in Canada, and then sport and exercise therapy in Germany, Switzerland, and the UK.
Well, to move on to the objectives, our objectives were to explore socio-demographics, so socio-demographic connections on IPE and IPC between various sports science, sports medicine professionals in healthcare, and as Tony told already, from an international perspective that is missing. And the second objective was to explore interprofessional perceptions and attitudes to generate approaches for the development of the professional education linking to sports science, sports medicine with interprofessional healthcare to enhance collaborative practice. So coming to the methods, what did we conduct? We conducted an online survey with focus on IPC and IPE, and we spread this survey in USA, Canada, and various countries in Europe, e.g. Germany, Ireland, Switzerland, Portugal, Denmark, UK, Norway, France, and Belgium, and merged them to Europe respondents. And how did we reach the respondents? Via direct mail or via mail distribution lists through professional organizations like European College of Sports Science or American College of Sports Medicine, World Federation of Athletic Training and Therapy, and several others, or via our direct personal networks, and as well as via social media like Twitter, Facebook, or Xing or LinkedIn. What were the contents of the survey called Interprofessional Collaboration in Sports Science and Sports Medicine? We asked for socio-demographics like age, gender, or employment settings. And we asked for attitudes and perceptions towards interprofessional collaboration and interprofessional education via the UWE, it's the University of West England Interprofessional Questionnaire. We also had open-ended questions like, you want to tell us something more, or what do you think about the profession athletic trainer? And before spreading out the survey, we did a validation. We spread it out to 12 international experts from our personal network and also from different countries to make sure that also in countries where English is not the first language, that the respondents understand the questions clearly. And to give some more insights into the University of West of England Interprofessional Questionnaire, I have this slide for you. This questionnaire consists of 4 scales from A to D. It's about communication and teamwork, interprofessional learning, interprofessional interaction, and interprofessional relationships. And each scale consisted of 8 to 9 items. And each item was rated on a Likert scale from 1 to 4. And please make sure that the higher the number is, the more negative the attitude or perception is. And what we did, we created a sum score for each respondent and scale, and classified them as positive, neutral, or negative attitudes according to instrument developers from Catherine Pollard and colleagues. And let's move on with the results. Tony, it's your part again.
So let's take a look at the results. We were very fortunate to have a nice yield of respondents in our survey, 320. of which most of them were 40 years and below. We had slightly more females, and we had a fairly good mix of from different countries. So we found that they clustered around certain areas. So we decided to create groups regarding the USA, regarding Canada, and then we created a group around European and a few other countries, but they all have kind of similar sports medicine landscapes in those countries that we clustered together in what we called the Europe group. Next slide. One of the issues in sports medicine is really hours per week. You know, most athletic events happen, you know, in evenings and off hours, and I think it was important that we were sensitive to the average amount of hours per week, and we did find that quite a few worked over 40 hours a week. Also, another thing we found that was very interesting was really the type of employment. So in the United States, the athletics is very closely tied to institutions, whether it be professional or academic institutions. So most of the people were employed in institutional level, whereas many more people in Canada and Europe were self-employed and entrepreneurs around the areas of sports science and sports medicine. If we looked at the kind of the profession mix in these groupings, athletic trainer of the respondents, athletic trainers were the bulk of the respondents in the United States, whereas in Canada there is a kinesiotherapist designation, and there's kind of evenly split between the two groups there, and then the physical therapist and athletic trainers, or some sort of version of that, whether it be sports and exercise therapist, you know, athletic therapy, something like that in Europe is it's a little bit, in our respondents, a little bit more with that group. If we look at the interaction with other professions, so one of the things we asked was, like, who are the professions you regularly interact with? And in the United States, it was athletic trainers, physical therapists, and physicians. Very similar in Canada. However, in Europe, it's a really a much wider mix, which is actually as expected because of the structure of sports science and sports medicine in a lot of the European countries, where you see a lot of different professionals working in that space. You know, that's a unique opportunity in interprofessional education, but it also provides some confusion and struggles, because many of them are not included in kind of some of the formal interprofessional education programs. Next. You know, and we want to just get a sense of how they feel that interprofessional collaboration has impacted patient-client outcomes. And generally, it definitely has a positive. Some found it had a mixed impact, but very few of them thought it had a negative impact or no impact. You know, we also asked if they had IPE as a learner. You know, and I think and from our research previously, we found that, you know, for the most part, there's been some interprofessional collaboration. I would say in the United States is far behind Europe and Canada, especially with regard to sports medicine, because in the US, athletic training is just a recent kind of collaborator in these interprofessional education programs. Gert?
Okay, thanks, Tony. Let's have a look at the UWE results. It's pretty much on the slide. I will guide you through those slides and scales respectively. First of all, please have a look at the slides or scales. A, communication and teamwork. B, interprofessional learning. And D, interprofessional relationships. And you see for all regions and in all scales, on average, we found very clear positive attitudes in those scales. However, and now you see this in scale C, interprofessional interaction. They were mainly rated as negative. And interestingly, the interaction scale asks if in sports science, sports medicine, professionals experience any stereotypes, status hierarchies, no open communication, or no equal respect. And if that is the case, then this scale is rated as negative. But you can say A, B, and D, they're very, very positive attitudes and perceptions. However, only in interprofessional interactions, there are those negative perceptions. And second, we found region-specific differences in scales B and C. In interprofessional learning and interprofessional interaction. Interprofessional learning, we have very, very positive values, significant different to Canada, Europe from USA. And in scale C, interprofessional interactions, we have less negative values in Europe compared to Canada and USA. And what we also found was that there were further significant effects of age and gender, and not to move too detail, to dive not too much into detail. There were effects in some scales, meaning that older respondents were more positive compared to younger counterparts, and males were more positive compared to females.
So when we look at the discussion, we'll first talk about demographics. So, you know, we found out, as we talked about earlier, we found a wide variety of demographics, because a lot of it is because there's this lack of clarity. I think Gert talked about it in his first presentation, that one of the gaps we find in interprofessional education, especially working internationally, is that there is such a variety between countries regarding kind of the structure of healthcare, the structure of athletics, and those types of things, and funding models. So, you know, I think, you know, really, you know, we're, you know, a lot of countries where, you know, people get invited to be at the table from an interprofessional collaboration standpoint is where they share kind of the funding model. And if you're kind of on the outside looking in, or you're an entrepreneur, those types of things, it becomes a little bit more difficult to be in those situations. Next.
Okay, concerning the attitudes towards IPC and IPE, we can conclude that on average, clearly positive attitudes towards communication and teamwork, interprofessional learning, interprofessional relationship were documented in each region, and only in interprofessional interactions, negative perceptions were found. That means for us, professionals in sports science, sports medicine, clearly value IPC and IPE, but they do not feel that the systems there in the USA, Canada, and Europe support IPC. And therefore, interprofessional activities in practice as well as in teaching in the field of sports science, sports medicine should be promoted. Yeah.
We had a very rich qualitative responses to some open-ended questions in our survey. We do not have the chance to delineate those now, but we do have a paper that was published in the Journal of Interprofessional Care that has a lot more information around it. And one of the very interesting responses we got, to give you an example, that one of our respondents says sports medicine is a multidisciplined, athletic trainers, physical therapists, osteopaths, radiologists, team physicians all work together. We can all learn from each other. So it is, interprofessional collaboration is valued, but like Gert said, there is a perception that sometimes it's not supported across all professions, and I think that's one of the things we need to strive for.
Yeah, and there's a small promotion for our webinar concerning this topic. Is healthcare a team sport? Widening our lens on interprofessional collaboration, education, and sports science and sports medicine, especially for Switzerland. And however, everybody is invited, and you can I can put it in the chat afterwards. And again, thanks, Anthony, for supporting us to promote this topic in Switzerland. And we're looking forward maybe seeing you in this webinar discussing this topic for Switzerland.
Yeah, I'm very just to let everyone know, I'm very fortunate to be able to go to the Winter Third symposium for Interprofessional.Global, and we're actually going to be doing this webinar in person. So I will actually be in Zurich with Gert at the CAIPE Foundation when we present this webinar, and with our colleagues Justin Gérard, Daniel Erlacher, and Claudio Nig. So it's going to be a tremendous opportunity. I really look forward to it, and thank you Gert for giving me this chance.
Thank you very much, and we are looking forward to this webinar, and thanks to have this presentation in common. We have to acknowledge, I think, Tony, it's 4 or 5 a.m. in St. Louis. So thank you very much for joining this webinar, and yes, if you want to reach out to us, please feel free to contact us via mail or Twitter or Xing or LinkedIn from Tony. And Tony already told that our paper is published in Journal of Interprofessional Care, and you can also download it from this journal. So thank you very much, and we are looking forward to the discussion.
Thank you both for another excellent presentation. Again, for me, I think one aspect was the challenge of terminology that's come up during your presentation. Yes, a big thank you to Tony for getting up at 4:30 a.m. and joining us this morning for a wonderful presentation, and excellent congratulations that you've got it published in the Journal of Interprofessional Care. Just to share with you, as it's the official journal of CAIPE, and Andreas Icarus, the editor-in-chief, is one of our CAIPE board members. The interest in the journal is going on boundlessly, and the number of downloads that have been achieved has increased tremendously, possibly due to the COVID pandemic, but it has led the publishers, Taylor and Francis, to increase the number of pages in each edition of the journal. So that's going to encourage more publications. So hopefully that's given people time to think of some questions, and we'll have a look. Anybody got a question? There you go. Good morning, Gabriella, again, and welcome. And we look forward to this last presentation this morning, but not least, and your development of professors' perceptions about patient safety teaching in an interprofessional education experience.
Yeah, thank you, Richard. Yeah, my name is Gabriele, and currently I'm a student at King's College London. And today I will present some of my parts of my study from my master's degree. And please let me know if you can see my PowerPoint slides correctly, because I see just another screen here.
At the moment, they're looking perfect, Gabriella.
Okay, so I've started to study that interprofessional education and patient safety are recurrent and linked themes within the field of healthcare worldwide, and international organizations supported by research evidence have called for health and social care professionals to learn how to work collaboratively and efficiently to provide safe and better care. But little was known about university professors' perspectives and experiences of any facilitators and or barriers they might be facing regarding patient safety teaching, is specifically reading on IPE experience. So I decided to study how professors were having their experiences in IP curriculum project, and how they could be including patient safety teaching with undergraduate health courses. When I was thinking about presenting my findings to the conference, these findings were not published, but this was published this year, and I was very happy. So more than half a century ago, the WHO published Health for All, and then the Framework for Action on Interprofessional Education Collaborative Practice was launched in 2010. And they made clear that we needed strategy to overcome the shortage of resources in our healthcare sector worldwide. And international literature showed that IP and collaborative practice could help us to improve patient outcome and patient safety. In 2013, in Brazil, we had a national patient safety program. And one of the main objectives of this program was to promote patient safety teaching during undergraduate health courses for both the public and private sectors. And it means that the universities and the professors should be including patient safety topics in their classes, lectures, and research projects. The Brazilian Ministry of Health has been promoting initiatives to implement IPE in undergraduate health courses, together with the OPAS, Pan-American Health Organization. And in July of 2019, the Ministry of Education launched a program called PET, Health Interprofessional, with a goal of trying to insert pedagogical project to promote IP initiatives in the undergraduate courses. So to better understand how professors were experiencing and perceiving their activities of patient safety in interprofessional education projects, we used phenomenology as a theoretical framework to focus on individual experience. And we tried to gather detailed data from our participants to understand the meaning of their experiences. And we proceed with an inductive approach to interpret their lived experiences and descriptions. And we wanted to understand how they were experiences their activities in that pedagogical project. So I choose a federal public university in Brazil, and the participants' recruitment was undertaken in 2 phases. So first, I was in contact with all the 140 registered professors in the campus by email, and it was a quantitative phase. And after that phase, we purposefully invited 18 professors with a criteria. So they must have been working at the campus since the creation of the pedagogical project, the Interprofessional Pedagogical Project, and be involved with the writing curricula and be regularly participating in the curricula committee meetings. So from these 18 invitations, 11 professors representing 6 different healthcare undergraduate courses agreed to be interviewed. All the interviews were individual, semi-structured, and arranged during professors' working time. We analyzed using thematic analysis following the Brown-Clark method, and we tried to focus on the IP experience in how it could be facilitating or not the patient safety teaching, rather than focusing on the professional background. And this study required formal ethical approval, so we proceed with this, and all participants received a consent form, and they did not receive any financial or any other incentives. It was voluntary. So the analysis of the participants provide us with 4 themes, and we could perceive some challenges and benefits working patient safety with an IP environment with the students. So these are our 4 thematic categories. Sustaining IP. So we found consultations with IP projects between professors, and they were recurrently telling us about unfair workload.
Gabriele, sorry to interrupt. Sorry to interrupt. Can you hear me?
Yes.
Okay. Are you sharing slides? Because we're not actually seeing any come up.
Yes, I am. I'm frozen?
Yes.
Uh-oh.
Let me just, do you want to try moving through your slides now and see what happens?
Yeah.
Apologies to interrupt you.
No, no problem. I'm on the results part. Can you see the figure 1?
No, we can't see any at all at the moment.
Oh, it's a problem. It's a problem.
Okay.
I don't know what to do, but let me try here.
Yeah, you seem to have the background screen only, rather than your...
Maybe like this.
That's good. Can you do the slideshow?
Can you see my slide?
Yes.
Sorry about that.
Okay, whether or not you want to whip us back through, or you could send this and then we can attach it,
yeah,
to record it. Sorry to interrupt.
Yeah.
Please continue.
No, I'm sorry. So this was one theme. The other one was a problem with stakeholder involvement. So the professors had no previous communication from the Ministry of Health and there's a gap between the Ministry of Health and Ministry of Education, and also a problem between primary care and what is the side for hospitals. And another theme was team learning. So professors were concerned about how students were learning how to create supportive network, how they could be learning to create interprofessional supportive network, and how students could be aware of self-care to deal with patient safety issues interprofessionally. And the last theme was pedagogy, how to use active methodology and how to best use rooms, lectures, and projects interprofessionally. So I will put some codes and then discuss of some codes. So for example, about sustaining IP, Professor 3 said, we have an insane teaching workload. Part of the period that I have with the students is there with the practical training. But for me to put the students in the practical training, I have a huge logistical challenge that does not appear in my workload. And suddenly in a teaching evaluation, this has no value because for being recognized as a good professor, I need publications. And Professor Chu said, we have a problem that escapes the university itself, which is the number of professors that should be greater to play a pedagogical project with this degree of interprofessional goal. There must be a lot of interaction between people, and there are many more hours in the classroom that do not count for me. So the analysis of the interviews provide insights into some of the key challenges and benefits the professors' experiences in the IP curriculum. But we see how they highlight difficulties with sustaining an IP project, which requires commitment on the part of the university and which reflects common difficulties reported internationally, such as lack of financial support, organizational and logistical challenges, securing clinical sites, and burnout among professors. They were also concerned with colleagues who did not participate in the curriculum project, and with new professors who had no previous IP experiences. So they told us about tensions between staff who are aligned with the IP and those who prefer to work uniprofessionally. And our findings suggest that other efforts should be made to foster a culture that embraces interprofessional practice, because it seems that professors were already burned from their IP experiences. I mean that they were already having too much trouble with the IP experiences to think about including patient safety strategies to the pedagogical project. And participants affirmed that they had to spend more time managing classes and practical activities, and they had no career progressions aligned with the university. So there was no locally agreed career development framework. So they felt like odds trying to work with the pedagogical project, but not aligned with the national system. The second theme was stakeholder involvement. When you leave the hospital environment and you go to people who live in their homes, and get sick, they have chronic problems. Then the question is, how does the program consider the singularity of those people? And then it's not a patient safety protocol. You see that it's a program mainly focused on hospital reality in the nursing team, medical team, right? Said the Professor 5. So a lot of professors said that the program was not looking at the complex system. They were focused on the tertiary system, the hospital. And they were disappointed about not being informed of the existence of the National Patient Safety Program. And this was a missed opportunity of a real integration of university and Ministry of Health organization. The third theme was pedagogy. There are the narratives, groups, and therapeutic approaches that we do with 2 or 3 students from different courses. They choose a case and follow it during a whole semester together. In general, these are chronic situations where they need to discover how to deliver care and how to improve health conditions for the patients. Professor 7 said it. So an equally important finding was a failure to measure the impact of IP initiatives. So professors' views were in line with evidence that indicates IP initiatives can improve collaborative teachings of patient safety, which can positively impact the quality of care. But they were concerned that their activities were not measured, and they were keen to know whether their efforts were making or not a difference. And without adequate evaluation, the professor could not judge their activities in long-term impact. And although it was not our goal to analyze our findings by professor's background, it was impossible not to notice that during difficult questions, or when I tried to ask professors questions that they were not so confident to answer me, or they were not very aware about the topic, there was a trend to focus on their expertise and not in the interprofessional general competencies. So for example, the professor with a nutrition background tended to focus on nutrition safety and nutrition patient focus. Or the professor from psychology background tended to focus on student psychological safety. So there were these moments of lack of confidence that professor tended to keep their discourse in their background comfort zone. And I found it interesting. And the last theme was team learning. To work in an interdisciplinary way is quite difficult, but we need to create conditions for having a network. You have to build your network, and it will facilitate patient-centered care. then the student and the patient will benefit from a good supportive interprofessional network. So from our reality, it seems that if we don't have the institutional support, we need to learn how to create our network. So we cannot wait for an institutional or national support. So professors were quite apprehensive how to teach students to create their own supportive network. And the importance of addressing the psychological safety of professional practice and have a psychology course integrated with other courses was seen as positive. Professors explained that psychology students were taught the concepts of self-care and therapeutic awareness, which enriched patient safety teaching with respect to burnout prevention in dealing with others' mistakes. And emphasizing the importance of student psychological safeties when dealing with errors and knowing how to manage pressures in practice settings, and how to encourage a more psychological safety atmosphere, and how to discuss about fears and mistakes, and how to have a more open discussion when things goes wrong. So the implications for practice in research is that we found that given the burden that professors felt from their IP experiences, more support is required from the university administrators. Sometimes it seems that having the IP pedagogical project is already there, but we found that it's disconnected with the career progression, and it might be hinder the progression and the well-being of the professors. Professors need the time and space to achieve greater integrations and develop their capacity to teach patient safety in the curriculum. And this would be enhanced if the university effectively communicates the national program and engage more professors with its agenda. So as I have said before, there is a huge gap between the Ministry of Education and the Ministry of Health in Brazil. It would also be beneficial if the professors were provided time and resource to explore IP theory and undertake evaluations of their work. So it seems that now there's no discussions about IP theory in practice there for professors. And having an IP project do not secure and do not guarantee that it will support professors, especially the new ones. Qualitative research would be beneficial to better understand the dynamics of how professors manage their work routine. So we need more research about how is the practice dynamic of these professors in daily work. And a related recommendation by ZX last year is to employ more observational work to generate data related to interactive processes that occur during interprofessional activities, rather than relying on individuals' perceptions. So yeah, we need to understand broadly what is happening daily today. So this is one limitation of the study. And there's a lot of limitations. One of them is that those who agreed to be in this study maybe is the most motivated and interested in IP and in the topic of patient safety. And it was collected in a particular geographical and social context in Brazil. And there's social disability bias, but we tried to provide a detailed contextual information so you can to understand what we were doing and how to reflect about our findings in a transparent way. And our conclusion is that in this setting, the patient safety has been promoted at a superficial level, and deeper structural changes have not followed to ensure its implementation and normalization in a day-to-day academic practice. Professors revealed key challenges related to their practice that paint a complex picture of maintaining an IP project. We need initiatives to keep the IP structure, and we need a patient safety policy to be integrated with the educational systems, because they come from different places and they are not integrated. And finally, wide interviews revealed professors' perceptions, including barriers and facilitators to teaching patient safety within an IP curriculum. We did not observe how this plays out in practice. So there is a gap to further exploration to enable a greater understanding of the structure and process changes needed to ensure the successful integration of patient safety into undergraduate IP curricula.
That was a very insightful, informative, and interesting study. I mean, I may not have perhaps looked for them, but it's very interesting to study professors' perceptions. And it would be interesting, wouldn't it? Because that was in Brazil, so a comparative study with perhaps the UK. Be interesting comparison to see what happens. But well done, excellent presentation. Thank you very much.